Palm Beaches. And I want to thank the folks we have with us here today, our Surgeon General, Dr. Joe Ladapo. We have Kevin Guthrie, the director for the Florida Division of Emergency Management, our ACA Secretary, and Marsteller. We also have Valerie Gray, who's a nursing home administrator here, Ken and Wayne Uffelman, who are going to talk about having received the monoclonal antibodies, Senator Harrell, and then Representatives Caruso and Snyder. Today, we're here to announce an initiative related to at-home testing. As many of you know, the federal government had promised to send massive amounts of that into American communities. Actually promised you could go online, request one, and they would just mail it to your home. That has not materialized, and so we've tried to look and say, where can we make an impact? I know the tests are scarce, but we've been able to work to be able to quarter some, and how would we then use those if we did have at-home tests? So we have acquired, we have the ability to send out up to 1 million at-home tests. And what we're going to start by doing is sending them to our nursing homes and our long-term care facilities. And then beyond that, we'll focus on senior-heavy communities. And the idea is our view on testing, Dr. Ladapo will talk about it, is if you're just young and healthy, you don't need to be running out and getting tested every day. Really, testing is supposed to lead to a clinical result, or what's the clinical response if you have a positive test. Well, clearly, when you're talking about long-term care facilities, you're talking about senior communities, those are the demographics that are going to be more likely to take a positive test and then parlay that into treatment, which we do support and want to get very quickly. So that will make a difference. It makes it better for the elderly. You don't have to wait in a line. The stores, I think, will start to get more in, but they go very quickly, and you have some people that'll buy up a lot of the tests, and it makes it tough. So the people who the testing is going to be very high value for, that's where we really want to see the access to. And so we are doing that, and this really follows from a lot of the policies we've had where we've tried to put seniors first, just recognizing that seniors are at greater risk. Now, fortunately, the Omicron variant is far less pathogenic than the Delta variant or even the previous iterations up to that point. What we're seeing is way, way more contagious. You're seeing it spread way quicker than you've ever seen any of the other variants spread. But the flip side of that is that it is less lethal, which is really good, and really is kind of what you would expect as a virus like this evolves into something that is going to be endemic. It's not something, and I've been saying this for a long time, but it's not something that's going to vanish off the face of the earth. It's something that's going to be here, we're going to live with. But between the prevention, the treatments, the acquired immunity, it'll be something that will not, hopefully in the future, impose really significant burdens on people in terms of clinical outcomes. Now, you do still see some people being hospitalized, but I think what we've seen in Florida is the people that are the most severe cases still tend to be the Delta cases. Most of what we see in Florida is Omicron, but it's not 100% Omicron. So we're in a situation now where we understand the deal. Most people are going to be fine, but if we do have vulnerable, whether it's Omicron or Delta, get that at-home test and then get the treatment, and that's something that'll be really, really good. I don't know if there's any prospect of the federal government. I don't even think they have the contracts done for this, and to have promised people could go online and order, that's a very tall thing logistically. I mean, we've worked through a bunch of stuff with the vaccines, with the monoclonals and everything, and some of this stuff is easier said than done. So we see an ability to help, and so then what we're going to do also is monitor the demand, how many other places, so it won't just be nursing homes or long-term care. We'll send them to places like we were at Kings Point when we did the first senior community vaccinations. We can send them to other types of things, and they just have it. And again, it's not really to just test, but someone develops a symptom, you go in, you have an at-home test, you can get a result, and then proceed to treatment. And that's something that's really, really good. The monoclonals, we have asked for, I think as many of you know, an increase in the allotment. We got severe reduction back in September. We were using them very effectively. You'll hear from some of those stories here. That reduction made it more difficult for us, but because we were able to do a deal with GlaxoSmithKline, we got thousands of doses to be able to paper through any type of interruptions. We didn't really see very much interruptions with the cuts that we saw because the demand declined very significantly. We had very low prevalence for a number of months. Well, now as you see the prevalence go up, you do see the demand for the monoclonals to go up, and we want to be able to meet the demand for our high-risk individuals, like in a nursing home, like our senior citizens. And so we were told earlier this week from the company that sources it that they were going to source the 30,000 doses that we asked for. Then HHS said, well, wait a minute, not so fast. Or does that? So the bottom line is we're just waiting. We don't know what's going to happen with it. Clearly, there's been a different approach based on what state is asking for it. I think that's very unfortunate. I don't think that should be the case, but that is absolutely the case. New York has people than we do. They're getting way more monoclonals than we are. And I got a lot of New Yorkers down in Florida as well that we take care of. And we serve everybody. I mean, you get your high risk and you go in for monoclonal. I mean, we're not making you show that you're a Florida resident because we want to help people. So you have all that, but that's just the reality that we're seeing. So we're going to keep fighting to do that. We have the ability to do a site in Palm Beach County, which we will do, Broward, Miami-Dade, Central Florida, Southwest Florida, Jacksonville, you name it. We already have a footprint, but this is a footprint that's only getting a very finite number of doses. And so as the doses increase, we then expand the footprint, accessibility becomes better, and then folks are able to get the treatment that they need. So we're asking for the 30,000. We have the infrastructure in place. We have resources in place. We asked the legislature after the Delta wave, we didn't know what was going to happen, but we said, look, if there's future waves, we want to be able to respond and meet the demand. So they set aside almost $1 billion in the legislative budget committee from October so that we have it. So we have everything we need except for HHS releasing the medication to the state of Florida. But I'm confident we're going to continue plugging away. But in the meantime, where we're not seeing the action on at-home tests, we're stepping in. This is a great start to help the nursing homes and the elderly, and we'll continue to expand in different communities as there's demand for it to be able to get these at-home tests. I want to thank Kevin Guthrie at Division of Emergency Management for working very quickly on this. Also thank Joe Latipo for he's going to be publishing the new testing guidelines. And again, we're a free state. We're not saying you can't. If you want to test every day, you can. We're not going to impose any type of restrictions. If that's something that if you want to go buy every test in CVS, it's a free country. It's a free state. But what makes sense from a clinical perspective, and Joe will lay that out in the memo, but basically the testing really, we want to tie that to outcomes that you're trying to get. And if you're just somebody that has no symptoms and you're not at risk for anything significant, to be going out and testing a lot is not something that's going to be considered high-value testing. Likewise, in workforces, to force someone to be testing before they go to work is not going to be really high-value testing. And I think the danger that you have for it is what impacts that could have on society. For example, we rejected the CDC's quarantine policy at the beginning of the school year and said, if you're symptomatic, absolutely, send the kid home. But if happen to be exposed, but you're healthy, to deny a child the ability to be in school, that has huge costs that are associated with that. And likewise, when you're talking about the workforce, if someone tests positive on a PCR test but has no symptoms, that may not even be live virus because you could test positive for a couple months with a PCR test. So that person may not even be contagious and have live virus, and yet they're going to be taken out of the workforce and be home. So that's a huge cost that happens with that. And so having a more targeted strategy, I think, will lead to better clinical outcomes. It'll make it easier for the seniors to get the test when they need it, but it's also not going to impose some of those costs on the back end that are not, they're not intentional costs. People are trying to be helpful helpful with the testing. I don't begrudge that, but at the end of the day, we need to make sure that healthy people, whether it's healthy kids or healthy workers, are able to participate in society. And so Joe has outlined that. He's going to be able to publish that very soon, and I think that will hopefully bring some peace of mind to some folks, because I think when the Omicron started going, a lot of people feel, oh, I got to go out and see if I have it or whatnot, and you really don't in the general circumstances. There may be special circumstances. We've always supported more rigorous testing with staff at nursing homes for obvious reasons because of the environment that you're in. But for the general public and the general, particularly the working age and school age populations, really the symptoms-based approach is the better way. So I'll let Joe Latipo come up here and do it, but we are happy to be able to have secured these tests in the midst of this shortage, and we're also happy that we continue to put our seniors first. Joe?
All right. Okay. Thanks, Kevin.